And we'll do the PowerPoint on anxiety and OCD first. Okay. Okay, so when we're looking at mental health, again, we're looking at mental wellness versus mental illness. And some of the books and some of the pictures that you can find online look at a holistic wellness. And we do know that you have to be well in all areas of your life in order for there to be good mental health. So if socially you have problems, occupationally, maybe your job or something's not going well, maybe you have a physical illness, all of those have to be in sync in order to be a holistic piece. So mental wellness versus mental illness, and we know that definitely all of these things 1 through 7 play a role in how well we are mentally. So the first thing we're going to look at is anxiety and a definition of that. And your book just talks about a vague feeling of dread or apprehension. Anxiety disorders, the key features are excessive anxiety with behavioral, emotional, cognitive, or physiological responses. So there's panic without reason. There's sometimes unwarranted fear of certain objects. Unexplainable or overwhelming worry. And wear and tear on the life of your particular body. So whether it interferes with your family life, whether it interferes with your children, maybe your job requires you to fly or something and you have an apprehension of being able to fly, an overwhelming sense of not being able to do some of those things, that it can interfere with your particular life and what is going on with it. So the first one that your book talks about is just a general adaptation syndrome, or Hans Selye is the guru on the general adaptation syndrome. And they believe that there are 3 phases that you go through. The first is the alarm phase. This is where the hypothalamus sends the stimulus to the adrenals to release adrenaline. This is the preparing stage. Then your resistance stage is your fight or flight. So you're either going to stay and put your dukes up, or you're going to run and hide. And then the exhaustion phase is the body has responded negatively to the anxiety. Your stores are depleted and your defenses are kind of down. So this is what they call the general adaptation syndrome. So if you think of things in your life that have caused you anxiety, did you go through these 3 cycles? The alarm, meaning you have a heightened response, you're preparing to deal with the stress. The resistance is the fight or flight. Are you going to deal with the stress, or are you going to flee from it? And then the exhaustion phase. This is the negative response to the anxiety. This is kind of the letdown, the stores are depleted. So if you think, you probably have all been in some type of situation where you've had some type of exposure to some type of whatever it may be that caused you anxiety. You have that release of adrenaline, so you're amped up, you're ready to go, but when the issue is over, you have a big letdown. You almost feel weak inside, almost kind of like a wet noodle. That's that depleting or that leaving of that adrenaline just kind of leaves you whipped. You may have done that if you wrestled, you played a sport event, you were on some type of academic team where you were all amped up for a debate team or something like that, and then the letdown. I know sometimes driving in bad weather, you get a little adrenaline rush and you're able to drive home white knuckled, but then when you get home, you're like, oh man, I'm just like weak inside. I just am like a big letdown. So that's your body's response to that anxiety. It's kind of that letdown phase. So that's a general adaptation. Your book also talks about some levels of anxiety, and they're on page 224 of your book. And the first one is a mild phase. It motivates people. It helps you focus on your exam. It helps you do well on your clinical, anything like that. It helps you do well for a job interview, those kind of things. Moderate anxiety, you display being just a little bit nervous or agitated. In severe phase or level of anxiety, you have some trouble thinking and reasoning. The muscles tighten, vital signs increase. There might be pacing, restlessness. So in the mild phase, it's a motivator. Because we always say if you're not a little anxious, then I'm worried about you. It's like you're too sure of yourself, and those are the people that make mistakes, because anxiety in the mild form is good. It heightens your awareness. It makes you more aware of your surroundings, those kind of things. If you're like, I have no anxiety, I know this, I got this, then I'm a little worried, especially in new situations, because anxiety is that motivator. It does heighten your awareness. Moderate is display of being nervous or agitated, pacing. Maybe you're starting a new job, so you're anxious at home about that, and you might be a pacer or somebody that's, tapping your fingers, tapping your foot. You can't sit there. You got to be up moving around before whatever takes place. Severe, you have trouble thinking and reasoning. Muscles tighten, vital signs increase. There's pacing and there's restlessness. In the panic phase, there's either fight, flight, or a freeze response. This is where you're going to get an adrenaline surge. The pupils may widen, and that you can see a physical response to that. Blood pressure can increase, so can their pulse. In the panic phase, they can be delusional or have hallucinations. They can be even suicidal in this particular stage. They don't really recognize the potential danger that they may be in. So panic is not a good thing. The next question is, anxiety, is it bad? Maybe yes, maybe no. It kind of depends upon how you handle anxiety. Do your levels get to that severe or that panic stage? Then that does interfere with everyday life, so it would be bad. There are warning signs that a person needs to assess and evaluate. Do you have too much stress? Do you not get enough sleep? Do you harbor negative feelings? Do you need to take a break? Do you need to ask for help? I mean, those are all things that you have to do a personal assessment with in order to see if anxiety is good or bad. So this is just a little caricature of norepinephrine, dopamine, and serotonin. And remember that all of these things, norepinephrine helps with your alertness and your energy. Dopamine helps with attention, motivation, pleasure, reward. So all three of those working together does mood. Dopamine and serotonin. Serotonin is your obsessions and your compulsions, and that helps you deal with anxiety. So we need those in a proper balance. We know when we talk about mental health disorders, some of these levels are off kilter. And so we take medications to put them in the right levels for patients so that they continue to be productive in everyday life. So for this particular patient, we're going to talk about triggers. So we have a trigger, and on your notes, we have a nursing exam. The thought being that I'm going to fail the exam. That increases the anxiety. They either have anxiety or you can have a panic response depending upon what the trigger is. And then the belief is, in this particular case, that I can't pass the exam. That triggers it again. Oh my gosh, you got a nursing exam. Oh, I'm going to fail the exam. Increases your anxiety. Oh, I don't believe I'm going to pass. So all of these things interact with each other. How do you break the cycle of anxiety? Well, some people will do that by therapies, medications. Some medications, the trigger is the nursing exam. The thought is, okay, I have an exam. I believe I'm going to do okay with this. The anxiety then is not there or only mild, because we said anxiety in itself is not a bad thing. If it's mild, it still causes you to want to study for your exam, still wants you to actively participate in things that will get you ready for your exam, and then your belief transfers to, I believe that I can pass the exam. So these are the cycles that patients deal with, and when it becomes negative is when we have negative thoughts, increased anxiety, negative beliefs, and the trigger just keeps happening over and over again. And you might have more than one trigger, especially for our folks that have panic attacks. So you can see the example, and I kind of rolled that into this picture here. So how do we work then as the nurse with patients that are anxious? Well, you have to have a self-awareness of your own anxiety level. If you're a highly anxious person yourself, you're probably not the best person to deal with the patient that's anxious, because they can read your emotions and you can actually make them more anxious. Just like your kids sometimes. If your kids are highly anxious, when you approach them and you're anxious, they're more hyped up. But if you can approach them in a nice, calm, soothing manner, a lot of times you can de-escalate your kids and get them to be in a calmer state. Assessment of a person's anxiety level using short, simple, easy to understand sentences. If you yourself or you have a family member that's ever been highly anxious, I'll use the example of go into a doctor's office or have a doctor come into your patient's room. They explain all of the information, they leave, and the patient looks right at you and says, "Now what did they say?" Those are examples of the patient's anxiety level is very high. They are only hearing a few bits and pieces, but not enough to be able to relay the story to you or to explain it back to you. If you would say, "Well, what do you think the physician said?" "I'm not sure. I don't think I heard him or her right." So a lot of times when you have patients that go to the doctor's office or even in the hospital, I will tell them, "I'm going to give you a piece of paper and a pen and you write your questions down," because they'll get in, they're highly anxious, they're listening to the doctor, and before you know it, the doctor's out the door and they'll say, "Oh, I forgot to ask them this, this, and this," because they're anxious. Their anxiety levels are high. And as a fault to physicians, sometimes they run in and out very quickly. But it's very hard for patients sometimes to sit there and rethink of what were the questions they had when they do have anxiety, especially they're ill, they want information, but they're unable to understand it or hear it because of that level. So writing things down, that sometimes will help for them. So use of short, simple, easy to understand sentences. Lower the person's anxiety to a moderate or mild before you proceed. Okay, so we went through those stages of anxiety, and they have to be in a moderate to a mild state before they're going to be able to listen or do anything for you. Use a low, calm, soothing voice. That's why we say if you're a highly anxious person yourself, you're probably not the best person to deal with somebody who's anxious. Safety during a panic level. Always provide for safety first. Okay, get them to a safe environment. If a room full of people is making them highly anxious, We're going to get them to a room where there's only you and the patient, or a smaller group of people, someplace where they feel safe. And then we can use short-term use of anxiolytics. And we usually, about 4 to 6 weeks is really all they want to put people on anti-anxiety medications for, just to see if that's going to help. Things like Xanax, Valium, Librium, Klonopin. So Xanax, Valium, Librium, Klonopin, something like that. Anxiolytics just short-term help the patient think a little clearly. It doesn't hopefully allow them to get to that above that moderate state of anxiety, because unless they're in that mild to moderate state, they're not going to be able to really function highly anyway. So we need those medications to bring them down to that mild to moderate. Hopefully in 4 to 6 weeks, we can work with them and come up with ways to help them deal more effectively with their anxiety, so they don't necessarily need anxiolytic medications, because they've found other ways that they can adapt and lower their levels of anxiety. Treatment for patients, this is a combination of medications or therapy. We talked about anxiolytics, the benzodiazepines are in there. Sometimes antidepressants can also be utilized for patients. They don't cure them, but they help relieve some of the symptoms that the patient is having. They can do cognitive behavioral therapy, and that's the little diagram that I have over to the right. Teaches the person a different way of thinking, behaving, or reacting to situations. And that's where a one-on-one therapy or a group therapy might also help for that too. For cognitive therapy, positive reframing, turning negative messages into positive ones, decatastrophizing situations, making them more realistic, making a more realistic appraisal of the situation. You know, is it likely? Could you survive this? You know, getting them to think more on a rational level. Assertiveness training, learn to negotiate interpersonal situations, turning them into I statements. I can do this. I won't do that. I can do this. Those kind of statements. So that's what behavioral therapy works with them on, or those three pieces, A, B, and C. Okay, so that is just a little snapshot of anxiety in general. Now we're going to talk about actual anxiety disorders. Oh, I like this little poster here. Slow down, keep calm, be positive, take it easy, breathe. And I look at that and I think, in reality, that's all great, but I don't have time for that. Nod your head if you think that's true. Yes. I can't see your head and you can't see mine, but I'm nodding. I did get to go outside the other day when the weather was better, and I think that did help my mental well-being, to be able to see the sunshine and a little warmer temperatures. But it's real easy to say these things. It's real hard to take time to actually do these things. You all have busy lives. You're either working, traveling to and from school and work. You have families that you go home to. Life just does not stop once you're done with us. So if there's one of the Post-its that you can take from here, take it and try to reduce some of the stress and the anxiety that you have, even if it's just the little smiley face Post-it. So, anxiety disorders. Incidence, 1 in 4 adults is affected by anxiety. They are more prevalent in women, people under the age of 45. If you're divorced or separated and you come from a lower socioeconomic status. Okay, So you've got those. So if you're divorced or separated, you may now be financially just one person. Now you may be handling children by yourself, or you're shuffling them back and forth between the other ex-spouse and you, or grandparents, etc. Maybe you're just separated. Maybe you were living with somebody long term and now you're by yourself. So now maybe you have an apartment that you can't afford by yourself, etc. Lower socioeconomic, they say money does not cure your problems, but money sure does help. It helps pay the bills. It helps you not worry about if you have insurance or not. It helps you not worry about if your car breaks down, if you can get a new car. It helps if you can afford the gas or the groceries. So money doesn't buy you happiness and love, but it sure helps reduce some of the anxiety in your life. Onset for folks can be variable. So in a panic disorder, this is the most common of the anxiety disorders that we have in the book. The definition for it is discrete episodes of panic, no stimulus for panic response. They can last somewhere between 50 to 30 minutes, and then they can intensify and escalate your anxiety. So you can see the little circle that I have there. They have the anxiety, then they have the panic attack, then you're fearful that you might have another one, which causes more anxiety, more fear, another attack, more anxiety, and it's just a cycle that keeps going around and around. The peak incidence for panic disorders is late adolescence to mid-30s. There are some physiological responses that occur when people have a panic attack. And you can see the little picture that I have on the side there. They could have anything from palpitations, sweating, tremors, a sense of dread or suffocation, shortness of breath, chest pain, nausea, abdominal distress, dizziness, paresthesias, chills, hot flashes. So these are the kind of things, if you were having these symptoms and you were never diagnosed with the panic disorder, you would show up to the ED with some of these things. So we would check you out to make sure you weren't having a heart attack, to make sure that you weren't having some type of GERD or GI issue, that you weren't having some type of stroke with paresthesias. All of those things would be ruled out. And once we've ruled all of those things out, then we might classify you or try to get you some help for some type of panic issue. So back on the assessment piece, sensorium or intellectual processes. So you can have confusion or disorientation with a panic attack. Sometimes your judgment or insight can be suspended. Self-concept, you blame yourself for having those or the issues, the problems that are going on. Sometimes it interferes with roles and relationships. There'll be avoidance of others. And then we said there can be a physiological or self-care concern. So disturbances in the areas of eating or sleeping when you have panic attacks. So panic disorders and the nursing process application. You can see here kind of the self-isolation and the kind of regressing to your own little hole while you're having the panic attack. You can see the lady is breathing into the paper sack over here because she's hyperventilating from a panic attack. So, two different things. This is inwardly retreating. This was outwardly having issues. So you can see, I'll put this back up here. I'll leave this here for a minute because here's your physical symptoms. So they have to have 4 or more of those in order for it to be classified as a panic attack. So 4 or more of those symptoms that I have listed there. Okay, hopefully you got those. If not, I mean, you can have just about any physical kind of symptom can be related into a panic attack. So, those aren't a definitive list of these are the absolute things that you have to display. There may be other things that people display based on their own panic attacks. Nursing diagnosis, these are kind of listed on 234 for you, but obviously a risk for injury. We said safety was an issue for folks, especially when they get up into that panic stage or that severe panic. Anxiety, obviously related to whatever. Low self-esteem, we said that was kind of an issue. You can see in the little caricature here that there's definitely something self-esteem wise while she's retreating into herself there. Ineffective coping. I mean, obviously, if we're having panic attacks, we are having stress in our life, but we're not able to deal with it appropriately. Powerlessness. Ineffective role performance. It can interfere with your job, with your relationships, with your relationships with maybe a spouse or a significant other, relationship with your mother, father, relationship with friends, children, etc. And then disturbed sleeping pattern. Oftentimes, folks with high anxiety will display that they have trouble sleeping at night. Their mind races. They can't take their mind off of the anxiety issue that's causing their problems. So what kind of treatments do we do for panic disorders? Well, that cognitive behavioral techniques that we talked about with just anxiety in general, your benzodiazepines, your SSRIs, your tricyclic antidepressants, maybe some anti-hypertensive like clonidine, maybe some propranolol like Inderal. Remember that your beta blockers will help with that heart rate. So people that have anxiety oftentimes will have high blood pressure and a high heart rate. So your antihypertensives will help work with that. Your beta blockers like your propranolol can help keep that heart rate within a normal range. And I would say when I have stress, my heart rate probably goes to 125, 130. I know that. I can feel it. Get kind of clammy, sweaty, those kind of things. And I talked with students the other day about, or a couple of you, about how as I get older, my anxiety gets worse. And I don't know why. I used to think I was a pretty calm person, but as my years pass, I have more issues with anxiety, have a lot of sleepless nights worrying about things. So I probably need to have a little self-diagnosis here. And sometimes I think I need medications for it, but I guess if you're self-aware and you know what's going on, maybe you don't need anything at all. Medications are based on the following. They're selected based on the client's target symptoms. So what are they actually displaying? What's the problems they're having? They must be given inadequate doses for some time before they take a full effect. So we know antidepressants specifically can take several weeks to work. Now, if in part of their anxiety piece is some type of self-harm, remember the less depressed a person is, the more energy they have to do something to themselves. So we do want to assess for that. Have you ever thought about harming yourself? And those are our new questions on our assessments when we admit people to the hospital or they do outpatient procedures where we're asking them kind of like little mini admission. Are you safe at home? Do you feel like harming yourself? Have you felt like harming other people in the last couple of weeks? Do you feel depressed? Those are all questions that we ask our patients now when they're admitted to any healthcare facility. We always adjust to the lowest dose possible, and then we can always go up from there. Older adults always start with the lowest dose possible because we know sometimes it doesn't take much for it to be effective in our older adults. Plus, if they would have any liver or kidney issues that we might not know about, those medications may not be getting excreted 100%. So we want to be real careful with them. Patients can experience rebound, a temporary return of their symptoms, or withdrawal if their medication is stopped abruptly. So we want to make sure that they continue with their medications. If they feel like they no longer need it, they need to contact their physician that prescribed it. maybe they need to taper down the dose, or maybe it is a medication that they can pretty much stop. So they need to have medical care for that. Follow-up care for these folks is extremely important. We want to make sure that they have compliance. It's like anything, we talk about compliance with blood pressure medications, and I have a bad habit of this too. Once you start to feel better, you're like, I feel better. Why do I need the medication? So you stop taking it. Same thing with these folks. Your anxiety goes away, you start to feel better, you stop taking your medication. But unless we've gotten to the root of the problem and you truly find out that you have better ways of adapting to your anxiety than having a panic disorder, the medications may need to always be there, just in very, very small doses. Compliance is greater accomplished with the simplest form and the simplest dosing. So if we started out and they needed 4 medications, if by the time we get down the road a couple of months, we can start tapering them back off and they can handle their anxiety fairly well, maybe we can get rid of their blood pressure medication, or we could get rid of their medication to control their heart rate because they have a better handle on things. So the least amount of medications possible, the better the compliance will be for these folks. Interventions promoting safety and comfort. The first concern is a safe environment and privacy. So I'm going to go back to this lady. If I have a patient who is having an anxiety attack, a panic attack, and they're short of breath, think now, I'm not so worried about the anxiety piece. I'm worried about her shortness of breath, her blowing off too much CO2, and her passing out for me. So if I came up to this lady who was hyperventilating, I would try to get her something that she could rebreathe in, and I would make sure she had calmed down her breathing before I would say, come on, ma'am, we need to go down the hallway here to another room and get you taken care of. Okay? So we say safety, but there's also a health safety piece to this. I need to make sure that she's not going to pass out once I get her up to move her. Okay, so don't get caught up in safety and those kind of things and privacy till you really have made them safe. And that is a physiological safeness as well as a mental health safeness. Okay, so I can't stress that enough. Therapeutic communication, simple and calm, so that they can understand. Remember, panic, they're definitely elevated there. They have a physiological response. They're not going to be able to listen to you very well until they start to calm down from that. Providing client and family education. They need to learn ways to manage their stress and stress-provoking situations, possibly medication, some teaching regarding their medication, follow-ups, regular exercise. Regular exercise does elevate your happy endorphins. It's kind of a pain reliever, makes you happy inside, within reason, because if I exercise too much, I'm not happy anymore. I'm mad and angry and sweaty. So there's a fine line there, but a nice healthy walk on a sunshiny day will elevate their mood. And then supportive organizations. And some people, you have to read them. Some people don't like going to therapies where it's multiple people. They don't want to share their problems, but they might do better with a one-on-one type program. Okay, I think all that was written there for you, so there's nothing to write down. The second type is a generalized anxiety disorder, or GAD. This is a chronic problem where they feel excessively or highly anxious at least 50% of the time for longer than 6 months. Treatment for this would be some type of anti-anxiety medication. SSRIs are often very helpful for these folks. Sometimes the anxiety is due to a medical condition. It might be temporary for them. So once they get their health issue under control, the anxiety disorder may go away. There may be something going on in their life, like a new job, a new position, something like that. Could have an ill child. an ill spouse, an ill parent, something that causes their anxiety. Substance abuse sometimes can induce anxiety, so we got to rule out that there's no substance abuse to that. And then remember, there are separation anxiety disorders, so you might have a child that's gone off to college and they're living independently and they could be having anxiety issues. You could have somebody that's newly married and now they're in a relationship and they've moved to Timbuktu because they have a spouse that's in the military or something. So all of those things can cause a generalized anxiety disorder. Phobias. The definition for phobias is an illogical, intense, and persistent fear of an object or social situation that causes distress or interferes with normal functioning. We have 3 categories that we'll talk about. Agoraphobia. Agoraphobia is the fear of getting out and being in large groups. So these are the folks that stay at home and won't leave their house. We have specific phobias, irrational fear of a particular object or situation. So it could be animal phobias, spiders, insects. Some people have dogs, cats, other things. Situational phobias can be fear of like tunnels, bridges, elevators, small rooms, airplanes. There's natural, environmental, like their fear of storms, water, heights, those kind of things. Then you can have social anxiety or phobia, anxiety provoked by certain social or performance situations. So it may be like work. We have, and I can't think of who it was, but sometimes you'll hear of actors, Barbra Streisand. She's much older, but some of you probably know Barbra Streisand. She has a very big phobia of being like out on the stage and singing in front of people, and yet she's made her living doing films and she's a great singer, those kind of things, but she actually has to take medication to control her anxiety in order to be able to get out on the stage and perform in front of others. That's why she does it very little anymore, because the anxiety is just pretty great for her. You'll hear of other singers, actors that have to take medications in order to do what they really like to do, but they like to do it not in front of a lot of other people. Okay, so it is not uncommon for social anxiety or phobias to be out there, but they control them with medications. So, things to consider when you're working with clients with anxiety or anxiety disorders. You need to understand how and why anxiety behaviors work. Remember that you as the nurse are just as vulnerable to stress and anxiety as other folks. Everyone occasionally suffers from stress and anxiety. Avoid trying to fix the patient's problems. And we're going to use techniques to manage stress and anxiety in your own personal life. So self-awareness pieces, and there's a page on 237 about self-awareness and anxiety. So again, I can't stress enough, when you're going through your book, you can read over it quickly. But then if you go always to the key points at the end of your chapters, and this was chapter 14 in your book on anxiety and anxiety disorders, it does give a little synopsis of the whole chapter. Plus doing your questions, the answers for those questions are always at the back of your book, so you have an answer and a rationale as to why the answer is correct or incorrect. The next piece we're going to look at is OCD. this is chapter 15 in your book on page 241. You can see that OCD, you can see a normal brain scan, looks good. But when you look at the brain scan of an OCD patient, there are physiological changes that are occurring within the brain. So it is classified as an anxiety disorder, but with unique manifestations in the way the patient attempts to decrease or control their anxiety. So kind of way different than somebody that just has basic anxiety. You will need to know the difference between an obsession and a compulsion. So if you would highlight those now or circle them. The obsession is the recurrent, persistent, intrusive, or unwanted thought, image, or impulse that causes the anxiety. And the compulsion is the repetitive, ritualistic behavior that you do in order to attempt to decrease your anxiety. Then you get relief temporarily. The obsession comes back. You have anxiety. You do the compulsion. You hopefully get some relief. The obsession, the anxiety, the compulsion, the relief. So it's cyclic for these folks. So some related compulsive disorders. There are some self-soothing behaviors, okay, to get rid of the anxiety. Dermatillomania is skin picking. Onchophagia is nail biting. Trichotillomania is hair pulling. So those are self-soothing behaviors that are compulsive. Some reward-seeking behaviors that are compulsive would be kleptomania, oniomania, compulsive buying, hoarding, excessive acquisition, and pyromania, fire setting. Now, hoarding, because of the hoarding show, that has really come to life. Excessive acquisition, most of those folks have some type of anxiety related to, so they have some type of obsession, something that causes their anxiety, maybe a loss. So they don't want to have that loss again, so they hoard items. That's their compulsion. That relieves their anxiety by keeping all of that stuff. But the obsession comes back. They have anxiety. They hoard more things. They have temporary relief. The obsession, hoard more until eventually you can't even get through their house. So what are some common obsessive thought themes? Contamination. So they fear that they've got germs or something on them. Possibly a religious preoccupation or blasphemy. Aggressive urges that they may have. Doubting obsessions. Accidental harm to others. There may be obsession on a sexual nature. So you can see the little caricature, nothing will happen if I check everything twice before I leave. There are 4 common compulsions that folks have. There's checking rituals, counting rituals, washing or scrubbing rituals, praying or chanting, touching, rubbing, or tapping, ordering, arranging, and rearranging, or exhibiting a rigid performance. So if you look at the picture that's there, does that bother anybody? Everybody's good with that?
I hate it.
And what don't you like about it?
That the brick is in the wrong spot.
Okay. If you look, it looks like they got this one. Let's see. See it below me. This brick and this one got messed up, right? Now it doesn't bother me, only I would think, you nincompoop, how could you put a red one in here and the black one in here and not know that? Now, we don't know, does this pattern continue on down the road? But for people that really have an anxiety issue about ordering or arranging things in a certain, it wouldn't matter if this was the pattern or not, this would bother them, that need all of these to be black and they need all of those to be red. Do some of you have issues with ordering certain things? So you have all of your shirts are on certain hangers or going a certain way, all of your pants are on hangers and going a certain way, or you colorize them. Some of you might be neat freaks, some of you might have issues with germs, so you're OCD on cleaning, sanitizing. Some people do have some compulsions that are mild. You know, as long as, I suppose a lot of people do have some form of OCD, their obsession and their compulsion. And it's not a bad thing as long as it doesn't interfere with your everyday life. If you just need to recheck the lock 2 times before you leave your house to make sure your house is locked, that can be done very quickly and doesn't interfere. But if I drive my car and I get to work and I've spent 15 minutes getting here, yet I have a fear that I've hit somebody on the way and I have to go my route again, that interferes with my everyday life. Now I'm late for work. Okay? So everybody, for the most part, has a little bit of OCD. It's just whether it interferes with your everyday life. So a lot of you know Amy Arnett. She helped with labs, maybe in your freshman level. And so I always bring Amy's name up because I didn't realize this, but she has an obsession. So she, obviously it causes her anxiety. Her compulsion is a counting. So if you offer Amy candy, she'll either take none, like if you only had one piece of candy, she couldn't take it because she has to have even numbers. So she either has to take 2, 4, 6, 8, 10, etc. She can't just take one. She said she needed also color. So like if she had yellows like her color, so she would do like every other. So if she had a yellow, a blue, and a yellow, she would eat the yellow, then the blue, then the yellow. Or food on her plate, she eats certain colors first. And she said, I've had some therapy in regards to my OCD, but she said, the doctor always said, if it doesn't interfere with your everyday life, you're okay. So she's like, we did this one time, she goes, haven't you ever noticed, like when I take M&Ms or something, I have to take at least 2, 4, 6, 8, or 10? Now, a lot of mental health disorders are inherited. So I said, Amy, just saw her the other day, I said, I'm going to ask you about your OCD. She goes, yeah. She said, it's evens. I said, does anybody else in your family have this? She said, my daughter does. She said, everybody thinks we're nuts, but her daughter is an odd number. So it's 1, 3, 5, not evens, is her compulsion when she counts. So like I say, everybody's got a little bit of OCD in them. It's just, does it interfere? So these are the folks that we're talking about. It does interfere with their everyday life. So we define OCD and assist in recognizing the patient's symptoms. We review the importance of openly discussing their obsessions, compulsions, and the anxiety that it causes. We emphasize that medication compliance is important with the OCD patient. And we discuss behavioral techniques for managing anxiety and decreasing OCD. So, suggestions for the family, because it would be very hard, especially if you're trying to get children going and getting them out of the house, and you have a child that has OCD about germs or leaving the home. It would cause a lot of anxiety in the parent. So teach the family to avoid giving advice. Teach the family to avoid trying to fix the problem. Teach the family to be patient with their own discomfort. Teach the family to monitor their own anxiety level. And give the family permission to take a break from the situation as needed. Okay, and like I say, those are listed in the book too. So if you didn't get them, or I'll put the PowerPoint up, you can always write them in later. So what do we do for treatment for our OCD patients? Well, it's a combination of medications and therapy, behavioral therapy exposure. This is deliberately confronting the situations and stimuli that they try to avoid. Response prevention, this is just focus on delaying or avoiding the performance rituals. So they may actually sign some type of contract with a therapist that says that instead of washing their hands 20 times before they can go on and do something, that they'll wash their hands 10 times before they can go on and do something. So they're kind of setting up some type of success plan so that they're not completely eliminating their response, their compulsion, but it is getting it under control so that it doesn't interfere with everyday life. Medications, the first line are SSRIs. The second line are SNRIs, something like Effexor. Effexor seems to be one of the medications that I see prescribed quite a bit anymore. And patients can take Effexor for depression. Treatment-resistant OCD, they can do second-generation antipsychotics, something like Risperidol or Seroquel, Zyprexa. And, it just depends on what works for your particular person. Sometimes the medications, first line will work, a little Zoloft. Other times, no matter how much medication you give, they just need to keep trying other things until they get something that will work. Again, it won't go away. They'll always have their OCD, but it is manageable and allows them to get showered, to get cleaned up, to get their laundry done, to get their house cleaning done without fixating on it, or to leave the house without fixating on germs and those kind of things. So there is a process that they can go through. You can see that on page 247 of your book. There's a Yale Brown Obsessive Compulsive Scale. We're going to look at their history. We're going to look at their general appearance, their motor behaviors, their mood, their affect. Is there overwhelming anxiety related to this? And then their thought processes and their content, are their obsessions out of nowhere, or do they have some type of altered thought that is causing this for them? So those are things that they're looking at when they're diagnosing the patient with obsessive compulsive disorder. And that is on 246. Okay, so that's where that was pulled from. And then the Yale Brown is on page 247. So we're looking at the assessment of them, their judgment or insight, and those are in there also. Self-concept, are they powerlessness that's associated with it? What are their roles and relationships like? And then their physiological and self-care considerations. Are there sleep issues? Are there hygiene issues? Are they unable to complete tasks because of that? Do they have poor appetite, unwanted weight loss in relationship to this, because all they get done doing is their compulsion? So what are some nursing diagnoses then for OCD that your book comes up with? Well, anxiety, obviously related to whatever the issue is. Ineffective coping, because that's what's giving the compulsion. Fatigue, because they have their obsession and their compulsion, so frequently it's interfering with sleep, eating, etc. Possibly impaired skin integrity, especially if they would be scrubbing or having some type of washing rituals, or they stand underneath scalding water in the shower, those kind of things to get rid of germs that can actually cause physiological issues for them. So interventions: therapeutic communication, supportive and encouraging, teaching relaxation and behavioral techniques. They must be willing to do that or participate in them. Completing daily routines, efficient completion of their daily tasks. So if they come back to the therapist in 2 weeks and they say, how's your daily routines going? And they're like, I don't get anything done besides my compulsion, then they're going to need to rework that. Providing client and family education. Glad to find the person isn't going crazy, because the family's probably thinking, what the devil? I yell and yell to tell them to stop and they won't stop. Compliance. Patient may need to try different medications. It is a process that they need to work through. If you get on and look at YouTube videos with people that have obsessive compulsive disorders, it's not an easy fix. Obviously, there's anxiety related to their obsessions, and until they can come and work through some of that piece, the compulsions probably are not going to get much better. They need to know or understand how and why their OCD behaviors work for them. You as the nurse need to know this also. OCD is a chronic condition where they have bizarre thoughts and behaviors. OCD is dependent upon meds, daily structure, which seems funny because you think most of OCD patients are fairly structured. Structuring meaning they only can do their compulsion so many times a day or for so long. Long-term behavioral therapy for them, and avoid trying to fix the patient's problems. There are some other disorders that are related to OCD. One of those is body identifying integrity disorder. This is a desire to be disabled. An amputation of one of their limbs is the desired outcome, or paralysis. Now, I can't imagine having that thought process, but this is a true disorder. So the desire to be disabled or paralyzed, and they really desire to have one major limb gone. Hoarding disorder, that's a real big one. Again, it's kind of come to light due to the TV show. And then another one is body disturbance disorder. And this is the one where they'll have so many cosmetic surgeries because they want to look like Barbie, or they want to look like Michael Jackson, or they have an altered sense of what they really should look like. And I can admit I've watched some of those botched shows where they redo the plastic surgeries, and even the two plastic surgeons, once the patient leaves, will say, I think they have a body disturbance disorder, because they want so many bizarre things done, or they've had so many surgeries that they look at each other and they think this just isn't right. That it's more of a mental health issue than a physiological piece that they want to have done. So you can read a little bit about that. Our main focus for your testing will be the basic anxiety disorders. What are they? And then your OCD. What is the OCD? How do we treat it? What does the OCD patient look like? And how do we treat them? So I'm going to let you go ahead and take a 10-minute break. Go ahead and